Hello and good evening, everyone. Welcome to our 64th Blue Health Virtual Seminar. Blue Health Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia, a medical consultancy company founded by medical doctors and a computer engineer. And we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge in preventive medicine. And I'm your host, Dr. Ihenot Adela, a general physician and first aid trainer from Blue Health Ethiopia. Today, it's a pleasure having Dr. Loza Wendmu to present on the operational deliveries presentation. So Dr. Loza Wendmu is an assistant professor of obstetrics and gynecology at Harame University. And Dr. Loza, the stage is all yours. You can start.
Okay, thank you, Dr. Ihenot, for a very nice introduction, and thank you, Blue Health Ethiopia, for creating this opportunity for all of us. Today, we are going to see some basic topics about operative deliveries. Operative deliveries are the most commonly done procedures in the labor wards, as you all know. So knowing the basics about this operative deliveries, whether it is operative abdominal delivery or operative vaginal delivery, it's very crucial for any health professional working in deliveries. So when we see today's lesson, I have divided it into two parts. The first part will be about the operative vaginal deliveries. So we will have some introduction, and we maybe list on some technical matters about operative vaginal delivery later on. So as an introduction, operative delivery is just refers to the broad range of interventions, either abdominal or vaginal procedures that are intended to assist her during difficult delivery. That's the whole point of this operational delivery. So operative can be, I already said, we can use different instruments in vaginal delivery to assist this in her difficult delivery, and WHO already assigned this assisted vaginal delivery as one of the 6 critical functions of basic emergency care. So operative vaginal delivery occupies around 5% of all deliveries, all vaginal deliveries, mostly vacuum delivery, and it has around 99% success rate if it is appropriately implemented on appropriate candidates. So that means there are some we should take before attempting any operative vaginal delivery. Should we know what's the behind? We should know before trying any operative vaginal delivery. One of these things is we should assess the presentation, and we should have the skill to assess the position, because it depends on candidates are very eligible for operative vaginal delivery. We should know the lie, we should know how to assess the station, and we should have a clinical knowledge about pelvimetry, pelvimetry. If we in this basic concept that we can easily detect which are the best candidates, we can fulfill all the prerequisites, and we can apply and achieve 99% of success. So when do we practice operational vaginal deliveries? What are the indications? One, when we have prolonged second stage, which can be defined with different. When we are talking about operative vaginal deliveries, we should know the indications first. So let's see some of the indications. I think here is where last time. So maternal indication that requires shortening of second stage of labor just to avoid the expulsive or big down effect of the second stage. And if there is non-reassuring fetal heart rate, or during after coming head in breech delivery and during acute emergencies, like it's similar with non-reassuring fetal heart rate, but during imminent cord prolapse or cord loops, nuchal cords, we can use operative. So what are the prerequisites in using instruments like vacuum or forceps? The prerequisites, some may differ in the usage of vacuum, or some may differ in the usage of forceps, but generally instrumental delivery, usually the presentation should be vertex. As you can see in vertex, this is specifically applied in the case of vacuum, because there are some scenarios we will use forceps in the absence of vertex presentation, in null presentations also. For example, in the case of fair presentation, specialized forceps in the after coming head in birth delivery we can use. So when we membrane should be ruptured, this applied for both instruments, and the cervix is fully dilated. This prerequisite also applies mostly for forceps, because in vacuum deliveries in very individualized scenario we can apply vacuum in late active like 8-9 centimeters of the cervix in a very skillful and very skillful personnel. So it is different for both instruments. So precisely known, it should be precisely known in both instruments. And maternal pelvis should be adequate, and it should be adequate analgesia, and the bladder should be empty, and there should be operators' willingness to abandon the procedure when it is failed. So that there are a lot of scenarios, including the cesarean section backup. Backup before the trial of instrumental delivery. There should be a backup for cesarean section in the setup. So based on station, we classify application of instruments based on station, and also need for rotation as outlet, low and mid. High is not included in the recently, it's already abandoned, it's not applicable. Most of the time we use outlets. To say outlet, the scalp should be visible and fetal scalp should reach the pelvic floor and the sagittal sutures. That means the position should be left occipital anterior or right occipital anterior. The fetal head should be in the perineum and rotation less than 45 degrees. And low, we are defining on the station +1, +2, that the rotation can be above or below 45 degrees. These are mostly applied, but mid station is between above +2, but it's not most of the time applied, especially forceps is not, it's very difficult to apply above low. So when we come to obstetric forceps, there are multiple types of obstetric forceps, more than 200, and there are historically associated history with the forceps. That is a triple obstetric tragedy that happened in Britain. You can read about it. But function-wise, forceps has two major functions. One, it can apply traction, and also it can apply rotation. So based on the need, we can apply both traction and rotation. So the cephalic curvation of the blade is designed to evenly distribute the force in the parietal bone and malar eminence. So when we see the anatomy, the classification based on function, classic, rotational, and specialized forceps, the anatomy of the forceps, you can see there is handle, blade, lobe, shank, finger guard, tool, heel, or curve. These are normally designed in different designs based on their applicable function. We can at least see 2 or 3 forceps in the coming slides. But the general anatomy, forceps are normally measured around 30 centimeters with when locked, the distance between the two tips are 2.5 centimeter, and the widest diameter is 9 centimeter in the middle. That is usually how we know that the narrowest diameter of the maternal pelvis also is similar to accommodate in that area. So when we see the classical forceps are normally used for traction when we need traction only. That is, rotation of the vertex is not required. So classical forceps are normally what we have seen in our works: the cephalic curve, the pelvic curve, and the English lock. This is the normal anatomy of the classical forceps. You can logically think, if we want to fix something and distribute the force and apply traction, we need a strong lock, strong locking system, and it should have a cephalic curve in order to hold the fetal head. So this is classical forceps. Normally, what we have in our work commonly is Simpson's forceps for traction. You can see it's the second in the left direction. So both branches are attached with English lock, and it has equal around pelvic curvature and cephalic curvature. So when we see about rotational forceps, these instruments are used mainly for rotation. when we need rotation. So having either one only or slight pelvic curve is having slight or none at all curvature in the curve. You can see that's why we need the pelvic curve, because it's rotational. We want to accommodate it. So in order to accommodate, we don't want any curvatures, so that we can minimize the risk of this trauma to the maternal pelvis. And also the look should also be sliding, because you can see in the next slide there are additional forceps, like the slight degree of axis traction is produced by reverse pelvic curve, reverse or curve, and the look should be, and the intersection point of the is longer. It's the head in barrier shapes. So based on the function we want, forceps are being updated and designed in different forms. That's why there are around 700 types of forceps in the world. So when we talk about specialized forceps are used in specific needs, like for example, after coming head, and also in the case of difficult cesarean deliveries, like then when there is an engaged head, you can use Hallis forceps, Hallis forceps. So Piper's forceps, you can see the design of Piper's forceps. It has long handles so that it can support the baby's chest during the application of the Piper's forceps in after coming head. So based on the function we design, there are multiple types of design. But when we come to vacuum extraction device, they are usually extraction, or we need for traction. They are developed around 1954 and usually have the suction, the flexible, and the cup. The cup can be stainless or plastic. And if it's plastic, it can be based on the shape, funnel shape, bell shaped, or mushroom shaped. They are being designed in different forms in recent years so that it could be more safe and also more effective in application of these instruments. When we see more of a technical things about the application of forceps, it's usually based on the training and skill lab other than giving lectures, but you can see each branch of the forceps are how it is introduced into the maternal pelvis with guidance of one arm and insertion of the other, and also we should make sure that it is properly guided into the pelvis so that it will minimize the risk of trauma. And we have to make sure that it is appropriately locked, because it's locked in different direction. It can cause injuries to the fetus and also for the mother. And on application, we have to make sure that posterior fontanelle should be 1 finger beneath or above the plane of the shank, and the sagittal should be perpendicular to the plane of the shank. And if it is frustrated, it shouldn't be, the frustration should not be palpable. So if it is applied that way, we can start the traction. So the traction, it should be begin with uterine contraction, and it should coincide with maternal pushing effort. During this time, the fetal heartbeat should be followed, and the descent should occur with each pull. And if no descent occurs after 2 or 3 pulls, the operative delivery should be halted and it should be declared failed. So when it is successful, and you have to know how to properly also remove the branches of the forceps, because it should be removed in the opposite order from that it was applied, and the fingers should also guide the removal also in order to protect the maternal pelvis. So vacuum extraction based on technical, when we see at least basic technical parts, there should be proper placement of the cup. It should be proper placement of the cup. As you can see from the picture, we should properly identify the anterior and posterior fontanelle. And from the anterior fontanelle, the flexion point should be 6 centimeters, and from the posterior it should be 3 centimeters. And we have to also check the maternal tissue entrapment during the pull-offs, pull-pops, and the gradual increment of the negative pressure, increasing the suction between 0.2 per kg to 0.8 negative pressure. That's very needed and effective pressure in application of vacuum. And there should be a controlled traction, because during these pop-offs you may interrupt some maternal tissue and result in injury. These are some of the injuries, especially with forceps, partial palsy or partial nerve injury, neonatal jaundice, and also scalp lacerations are mainly associated with this forceps delivery. And also maternal perineal laceration and blood detachment, especially in the case of vacuum, and also cervical incompetence in the future, and also future pelvic organ prolapse are strongly associated with instrumental deliveries. So each instrument, either vacuum or forceps, it has its own other. So mainly we can say vacuum is more preferable than forceps, because it's most commonly applied. When we see some of the advantages, the need for anesthesia is not that much in the case of vacuum, and also in vacuum it doesn't require any additional space beside the head. That's also advantage, and less genital tract laceration and less compression force on the baby, and it can be applied before the full cervical dilation, and it can be also tried in engaged head in mid or higher application instruments. It's also, there's advantages of forceps over vacuum, like it can be applied in case of intrauterine fetal days, in case of premature babies, in case of when there is retroviral infections in the mother, and also it's more effective in case of success when we see, because in vacuum you can apply your own pressure also. Okay, now when we go to part 2, we are going to discuss about operative abdominal delivery, cesarean sections, their indication, pre-operative and post-operative issues, and some of the technicalities about the cesarean section. And when we say cesarean delivery, it just defines the birth of the fetus via laparotomy or hysterectomy. And the rate of cesarean section has been increasing in the past years. You can see the data from 5% to 33%, and now it's around 60%. But this 5% is very early times in 1960s, but currently in 2030 it's around 32%, and for the last 5 years it's above even 33%. So that's why the WHO has proposed an incidence of cesarean delivery between 10 to 50% as target to optimize maternal and perineal health. So when we see this 10 to 15% in Ethiopia, still in different institutions, we can get a data above 20%, but as a country, it's less than 2%. Exactly. So why is the cesarean rate increasing very rapidly? What's the reason? One is the maternal age. Recently, the age for the first baby, especially newly pairs, have a high rate of cesarean delivery. Women are having few children, and for the indication of this late first delivery, one of the factors have been indicated, and the use of ECG is also it's widespreading, and it has increased the rate of cesarean section. And also the fetus with bridge presentations are now preferably being delivered by cesarean section. That's also one of the factors. It's because of fear of malpractice litigations. That's one of the reasons for the increment. And also obesity has played a role, and also assisted reproductive technologies, because babies with assisted reproductive technologies are more likely to be delivered by cesarean section, and that also has contributed to the rate of cesarean section. So what are the indications of cesarean section? Can be divided by absolute indication, where there is no possibility of vaginal delivery, or it can be relative indication, where possibility of vaginal delivery is there. but higher risk of fetal or maternal morbidity with this vaginal delivery. So it's preferred to deliver with cesarean section. Other classification is vital or prophylactic. When you say vital, it's done to prevent immediate life-threatening conditions. And if it is prophylactic, it's done to prevent future complications. We see with examples. When we see prophylactic, it can be maternal, fetal, or both. In maternal, it can be maternal illnesses like previously non-contracted pelvis. In contracted pelvis, we can say, but in this delivery, if it's attempted to deliver vaginally, there might be cephalopelvic disproportion, it can be obstructed labor, uterine rupture up to maternal days of severe bleeding. So that can be prophylactic. In order to prevent that, if there is already no contracted pelvis, we prefer the cesarean section. When we see in fetal placental dysfunction, hypoxia, this both the most common cause for both maternal and fetal prophylactic indication is CPD or cephalopelvic disproportion and malpresentations. When we say fetal, in the case of respiratory failure, first failure, severe hemorrhage like APH with active bleeding, I'm sure all of you has faced this indication. It's one of the vital indications, and also fetal asphyxia, prolapse, these are vital. And both fetal and maternal, in the case of eclampsia, uterine rupture, placenta previa, or abruption, these are vital, both fetal and maternal indications. And when you see in general data, the non-reassuring fetal rate and labor abnormality compromise more than 50% of patients for cesarean section worldwide. And based on the urgency, we can classify cesarean sections based on categories. Category 1 means there is immediate threat to the life of the woman or the fetus, like in the case of cord prolapse, in the case of non-reassuring fetal heart rate pattern, in the case of uterine rupture, in the case of APH with active bleeding. In these cases, there is time urgency. Normally, this type of cesarean sections should be done in less than 30 minutes. There are a lot of discussions about the reliability or feasibility of these 30 minutes in developed and developing countries, but based on the ACOG recommendations, less than 30 minutes. And when we see category 2, maternal and fetal compromise, that's not immediately life-threatening. There is a threat, but it's not urgent. Like it can take time. It can take more than 1 hour or 2 hours in the case of category 2 cesarean sections. And this is example is pelvic disproportion, cephalopelvic disproportion or CPDs. We can take time for preparation, but since there is a compromise, but it's not immediately life-threatening. In category 3, there is no maternal or fetal compromise, but we need early delivery, like in the case of previous multiple cesarean scars, in the case of previous contracted pelvis, in the case of already known placenta previa, for example, it's non-bleeding. Normally, that is we need to do the cesarean section in category 3. The time limit is not fixed. In category 4, elective, as the delivery suits or a woman or staff. In this case, it can be cesarean section by maternal request. In that cases, we can take our time, we can plan. Both the woman and also the staff can plan and do the cesarean section as feasible. These are the categories of cesarean section based on the time frame. So what things are considered as a preoperative management? Preoperative management before the cesarean section. For example, as you all know, cesarean section can be as urgent most of the time, because we are doing more than 75-70%, we are doing emergency cesarean sections, category 1 and category 2. But if we have time, it's recommended to have 2 hours from clear liquid or 6 hours from light milk plastic time, and there should be placement of the IV line and infusion with isotonic solutions preparation. And based on the placement of Foley catheter, there are also multiple recommendations. Recently, they are saying if she urinated, there is no need of inserting the Foley catheter before cesarean section unless it is indicated for other purposes based on her maternal condition. If it is elective cesarean section, normally she can urinate before the surgery, or there's no need of placing the Foley catheter, and antibiotics should be a must. And anyone before the cesarean section should know the laboratory summary, like for example the hemoglobin of the patients, the blood group, because it's very important in the preparation before the cesarean section. So when we see the technical matters, we are usually doing the fenestrial care cesarean section, that is based on the laparotomy and based on the laparotomy incision and based on the hysterectomy incision. Based on the laparotomy incision, it can be suprapubic transverse incisions. Most of the time we are using fenestrial incision, but mylar and jocoin are also being used. And the midline, it can be infraumbilical midline, or vertical incisions can be used. And after the entry, we may need to do the bladder reflection. And there are a lot of discussions regarding the technical matter. This is just an introduction I'm telling you, because we can talk more on the need of bladder reflection and also the preference of fenestrian or jocoin incision. These technical matters can be discussed in another session, I think, based on the surgical skill. And the other is about uterine incision. We usually do the car incision or smiling incision on the over the uterus, and need to elevate the fetal head and deliver this incision in the lower uterine segment. So the consecutive delivery of the fetus is similar with vaginal delivery. We have to hold the head and deliver the shoulder on and on. And the delivery of the placenta, we usually deliver the placenta with uterine massage and also continuous contraction. And we should repair uterine repair and abdominal closure, as I have already said. About types of uterine repair and techniques of uterine repair, you can further read. And there will be stepwise abdominal closure. So postoperatively, what can we do? The routine postoperative assessment of any fetus, any woman should be there, in addition to the monitoring of uterine tone and vaginal bleeding in the immediate postoperative time. And there should be fluid management, analgesia, and initiation of breastfeeding should be important in postoperative care after the cesarean section. So what complications can we anticipate? After? It can be immediate, intermediate, or late. In immediate indications, we can see hemorrhage, wound, complications, and also iatrogenic bladder or bowel injuries, and also especially in the case of repeated cesarean sections and the presence of radiation, we can anticipate this complication. And also neonatal complications like TTN is expected after the cesarean section, and also fetal laceration in 1 to 2% of the time we can face. And intermediate, there might be infection, venous thromboembolism, and later on it may lead to fistula and having few children, sub infertility, and scar complications like rupture. There's multiple complications. I just want to highlight both the operative vaginal deliveries and also operative abdominal procedures. And I would like to say some things about destructive vaginal delivery, because if we talk about operative deliveries, it's difficult to miss this topic, even though it might be new. It might feel like it's new and different concept. We usually, as an obstetrician, we use these techniques in some unavoidable circumstances, and anyone interested in gynecology and may practice in low resource countries like our country, they should be able to understand the need for skill in destructive delivery. And destructive deliveries can be types. There can be decapitation, craniotomy, evisceration, clitotomy, and also there are others. like any operative vaginal delivery, in destructive delivery, we should see the prerequisites. Obviously, there should be, we have to make sure that the fetus has died, passed, and the cervix should be fully dilated, and the baby at least should be engaged, and make sure that the uterus is intact. So prepare like any abdominal procedures. Okay, put on IV drip, prepare the laboratories, antibiotics should be given, and aseptic techniques as much as possible should be implemented, and there should be pain management, and OR backup should be also there. And the patient should be in lithotomic position, and she should be catheterized, and the bladder should be empty. So when we talk about craniotomy, the rate of the dead fetus is perforated to evacuate brain tissue in order to decrease the size of the head so that it can be delivered easily. And indications, like in the case of obstructive labor with intact uterus and dead fetus, we can prefer to do craniotomy, and also cephalic, like bro or face presentation, or in the case of interrupted after coming head. And what are the signs of craniotomy? Usually, in the vertex presentation, we use the parietal bone, and in the face, we can use the orbit or heart palates, and also in the case of pro, the frontal bone. And as you can see, after perforation, we can pull with using large pairs of forceps, so that could assist in the delivery of dead fetus. And this decapitation, usually it's about severing the fetal head after the obstructed labor or by delivery of the trunk. This usually is done in the case of neglected shoulder presentation or interlocking head of twins. It's evisceration. Usually it's removal of the thoracic or abdominal contents through the opening most accessible site on the abdomen or thorax. Usually it's also done in neglected shoulder presentations. When the dead fetus neck is not accessible for decapitation, like if there are malformations, we can use evisceration. Clidotomy, we can also use it in the case of allied bleeding, that is as a last resort in shoulder dissociation. But here it may, clidotomy is intentional fracture of the clavicles of the fetus. So we can reduce the bulk of the shoulder guide, and we can assist in the delivery. So clidotomy can apply in a live fetus also in the case of shoulder dissociation as last resort. So complications, usually in the case of destructive delivery, there is heterogenic uterine rupture or cervical or vaginal lacerations in postpartum hemorrhage, and there might be the development of vesicovaginal or vaginal fistulas. And don't forget the first prerequisites in the delivery of the destructive delivery is the baby. Make sure that the baby is died before trying any destructive delivery. And post-destructive operation there is really similar. We should keep the catheter up to 7 to 14 days, and after the procedure, the uterus, the cervix, and the vagina should be exposed for any injury, and she should do protonics, and if there is an infection, it should be treated. And I do vital sign report should be followed as if it is operative vaginal, as any cesarean deliveries or obstetric emergencies. And also we have to help a woman mourn her loss, okay? Because it's also grief counseling, and counseling about future pregnancy is very important in the case of destructive delivery, because we shouldn't only think about the psychological impact it will have on the physician operating or doing destructive delivery. It's also difficult for the woman and for the family to accept this as a mode of delivery, and so their loss should be mourned, and there should be counseling after delivery. So I think this is my slides, and so it will be complete after we discussed. This is one of the powers that I like the most. So thank you for the opportunity.
Thank you very much, Doctor. It was a nice presentation. I believe we can move on to the question and answer section. So one participant asked, yeah, we can move on, right, Doctor?
Yes, yes.
Okay. One participant asked, how do you see the current practice of sales delivery in our country? I mean, as compared to the WHO data, if possible. Thank you.
The current practice of cesarean section in our country in general has increased. It looks that it is increased. The WHO recommended 10 to 50% rate, cesarean rate in the country, but when you see as a country level, it's still less than 2. So it's not high. It's not high. The cesarean section, we might see a lot of cesarean sections comparing with the previous years, but as a country, we are still in the target group because it's less than 2%.
Okay, Doctor. So Emmanuel Mamuye asked, what do you suggest about the management of anencephaly regarding the cultural impact?
Okay. In the case of lethal congenital anomaly, usually the preferred mode of delivery is always vaginal delivery. So if it is anencephaly, there is a high chance of delivering vaginally. So vaginal delivery is the preferred mode of delivery. So I don't know whether your question is to abort it or to continue the pregnancy, because that is another topic. But regarding the mode of delivery, it's preferred to vaginally. We might not need even the operational deliveries in the case of this anencephaly. How is the current recommendation on operative vaginal delivery, forceps practice, and associated malpractice litigations raised when a fetal coma is ensured? This is a very important question, because even the application of forceps delivery is nowadays reducing, because even the residents and also maybe some seniors, they may not apply forceps just for fear of this malpractice litigation. But the skill of an operative vaginal delivery is still in Ethiopia. It's recommended, and everyone should know and learn about this operative delivery and applied, because there are strict rules. And as long as we follow the prerequisites, as long as we follow the indications for operative vaginal delivery, the complications are also there, and the woman should give consent before applying any instrumental delivery. So if the woman give consent for the procedures still have, still they are recommended to be applied and preferred more than the. How many, Singtan Lamisa said, how many cesarean sections are allowed? Usually there is no specific number that's recommended to have repeated cesarean sections. There are case reports about 10 or more cesarean sections in one, tens of cesarean sections. In our country, we usually have faced mothers more than 6 or 7 cesarean sections. So there is no fixed number of recommendation for cesarean section or to be allowed for repeat cesarean section. Yeah, it's unlimited. There are also associated question about cesarean section rate. There is no fixed number. So what do you recommend, more effective cesarean delivery or vaginal delivery? Vaginal delivery 100 times, because it's very natural and it has more advantage than cesarean section. As you can see, cesarean section has multiple complications, both on the mother and also on the fetus, and if you do the first cesarean section, means you have put a scar on the mother, and that will be included in a her reproductive summary every time. No? So if there is vaginal delivery, I will 100% recommend vaginal delivery. That's why the WHO have also put forward the recommendation to limit the cesarean section rate less than 15%. So what's the recommendation to do cesarean section during meconium stained amniotic fluid back to the stage of labor and grade of meconium stain? And also recommendation about interpregnancy interval. This is very important to know because the interpregnancy interval, it's usually 18 months, but if it is a delivery to pregnancy interval more than 6 months, it's recommended. And about the meconium stained amniotic fluid, we usually do cesarean section in latent first stage of labor with meconium stained amniotic fluid. If it is above, if it is grade 3 meconium stained amniotic fluid, that's associated with lack of continuous monitoring in our wards. If the recommendation, if there is continuous monitoring, we can monitor the fetal heartbeat and allow labor, but we don't have that. That's why we are doing. But in the active first stage of labor, we can follow mothers with meconium stained amniotic fluid regardless of the stage of labor. That's it.
Yeah, thank you very much, Doctor. On behalf of Blue Hills Ethiopia and all our participants, we thank you very much for taking the time to present on our platform, and we hope we will be having you in the future with other topics as well. Thank you very much, Doctor.
Thank you for giving me the opportunity to share this with you all. Thank you.
Thank you, and good night, Doctor.
Okay.